Good morning, Michelle. Do you need to do a sound check?
Good morning. How are you today?
I'm well, thank you.
All right. You are completely clear.
Okay, thank you. Do you have everything that you need?
I do believe. There is an one that in the phone number ends in 81 on the screen. Who is that?
I am not entirely sure.
Okay, I would probably need that name if they're going to speak. But other than that, everything else is good.
Thank you.
Thanks.
Good morning, Robert. Esteban, do you guys need to do a sound check?
Good morning. Good morning.
Good morning. Good morning, thank you. Morning, Thomas. Would you like to check your audio as well?
Sure, thank you. Good morning.
Sounds great. Sounds great. Thank you.
Morning. Michelle, are you here?
Good morning, I am.
Hi, great. Are you all set up?
Yes, I am. Just let me know when you're ready.
Okay. Mr. Garcia, is everyone here from SVMC?
Yes, sir.
Great. All right. Nice to see you. Nice to see you, Mr. Green. Thanks for both being here.
You too,
I'll
Chair
call-
Foster. Thank you.
Thank you. I'll call to order the Green Mountain Care Board's hearing of August 7th. And Michelle, we can go on the record.
We are on record. Thank you.
Okay. Good morning. We are continuing hospital budget hearings. Today we have 3 hearings. First, we have SVMC's presentation from 9 to 11:30. Then we have Northwestern Medical Center 12:15 to 2:30. And then last but not least, the Rutland Regional Medical Center from 2:45 to 5 p.m. Mr. Garcia, I'm going to have our counsel, Ms. Korelman, swear in the witnesses. And what she'll do is she'll read the oath, and then each person who's testifying on behalf of SVMC can affirm the oath and say their name.
Thank you.
All right. Thank you very much, Chair Foster. So I will start by reading the oath. Do you solemnly affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalty of perjury?
I do. Esteban Garcia.
I do,
Robert
Thomas
Lava.
Green. Oh, sorry. Go ahead, Bob. I do, Thomas
I do.
Green.
I do, Robert Lava.
That is it.
Great. Mr. Garcia, we'll turn it to you and your team for any presentation or comments you have.
Great. Thank you so much. Good morning, Chair Foster. We'll put our slides up. Good morning, Chair Foster and members of the board. I'm Esteban Garcia, President and CEO of SVMC. As SVMC's new CEO, I welcome the opportunity to continue our work with the board to increase affordability and access to healthcare. Joining me today are Bob Lava, our Chief Operating and Financial Officer, and Tom Green, our board chair. We look forward to discussing our 2027 budget. I'll start by briefly introducing myself. I've been practicing pediatrics and pediatric emergency medicine for more than 30 years and have been involved in hospital and health system administration for more than 20 years. In addition to my clinical and administrative roles, I served as the Massachusetts Department of Public Health Chief Medical Officer, in which I had clinical responsibilities and oversight of the state's 4 public health hospitals. I've now been at SVMC just shy of 7 months, and I've been also serving as interim chief medical officer. SVMC is a comprehensive rural community hospital serving Bennington and Windham counties in Vermont and communities in New York and Massachusetts. Next slide. We provide the majority of our primary and specialty care across our service areas. As you are aware, SVMC answered the call from the state to build an adolescent medically complex behavioral health unit that we anticipate opening in April of 2027. Next slide. We were founded over 100 years ago, employ 1,300 staff with 230 providers. Next slide. Here I'll highlight that we received our 6th Magnet recognition for nursing excellence this year. We're one of only 3 hospitals in New England and 32 hospitals worldwide to have obtained 6 consecutive awards. This recognizes the excellent nursing care and culture at SVMC. In 2023, we joined Dartmouth Health as one of 7 rural hospitals. Integration is ongoing, merging HR, IT, and administrative services. Improving and expanding clinical care is driving our integration. With the help of DH, we are expanding oncology care, inpatient dialysis, cardiovascular, surgical, mental health, and primary care. The ultimate goal is to keep care for Vermonters in Vermont. Next slide. I'd like to focus on my vision to anchor SVMC in primary and preventative care now and into the future. We have immediate, medium, and longer-term plans to make this happen. We've hired several new primary care providers using J1 and HB1 visas to fill positions that have been open for years. We've launched the Bridge program to support inpatient, emergency department, and urgent care patients without primary care while we bridge them to one of our primary care practices. We are well on our way to launching our family medicine residency program in Bennington under the Dartmouth umbrella. Our goal is to welcome our first class of 6 residents for a total of 18 residents in July of 2029. This will require significant investment of our time and resources, but is key to our future and sustaining our provider network. Next slide. In addition to our clinical integration, non-clinical service integration is moving forward as well. As we look to the next 2 to 5 years in partnership with DH, we are focused on keeping care local, leveraging efficiencies through shared administrative services, group purchasing, launching Epic as our EMR, and expanding telemedicine. 2026 has been a year of transition for SVMC with the retirement of Tom D. after 16 years of service as CEO and the departure of our longstanding Chief Medical Officer. Change is difficult, but the SVMC team is committed to serving our community and embracing our future. I'll wrap up my section by highlighting the launch of our strategic planning process. Now more than ever, it's important for us to partner with our staff, providers, community, legislature, and regulators to develop a roadmap for the next 3 to 5 years. Bob will elaborate on our direction to Ovation Healthcare, our consultant leading the health planning process. We hope someone from the board is available to participate in this process. We've already spoken with AHS and other state leadership. It's an exciting time for SVMC, and we look forward to this discussion. Thank you. Next slide. Bob, I'll hand it to you.
Great, thank you. Good morning, Chair Foster and the rest of the Green Mountain Care Board. Going to start by going through the executive summary of our 2027 budget. This budget represents, except for a few key areas, a very similar budget as our 2026 from a service perspective. So we're going to take this time to really describe how SVMC is viewing transformation and efficiency and how we to become a strong hospital within the reimbursement changes that are ahead. Most of our utilization statistics, payer mix, et cetera, are all staying relatively consistent with no material change. All of our utilization statistics have less than a 2% variance to what we expected in the approved 2026 budget. This budget represents no reduction in services, and we are only adding services to increase access to care and to reduce healthcare spending. We have guiding principles that we have in developing the budget. These are principles that are must-dos and are non-negotiable. One is to stay within the guidelines set by the Green Mountain Care Board, which we will go into the details on how we were able to do that. We need to increase community benefits through access to care, always increase our value and our quality, as well as continue the work with Dartmouth in order to be fully clinically integrated. The major assumptions that we have in this budget, first is the 340B program. We talked a lot about this at our last budget hearing, as SVMC was anticipating not being eligible in for the full 2026 fiscal year. Thankfully, we met our eligibility requirements and were able to stay within the program. So we did inform the Green Mountain Care Board as soon as we found out that we were in the program. So this SVMC savings is incredibly important to the services that we're able to provide and allow access to increased services, especially on services that are more difficult to scale. Our ED inpatient volumes, very little control on who comes in and who we need to take care of. OB is another area that is an expensive service to provide, that we're able to use our 340B savings in order to help continue that program. It's a complex program, but our 2027 budget, we do assume that we will be eligible for the full year. So this budget represents additional costs and additional other operating revenue related to the program that was not in our 2026 budget. We won't fully know whether we qualify until the February-March timeframe when we file our cost report. but our tracking shows that we are within the eligibility requirements as of today. The bridge program that Dr. Garcia mentioned. So this is really helping to address the lack of primary care access. So as patients are seen in the emergency department or are have an inpatient stay and do not have a PCP, they will be referred to the provider in the bridge program who will take care of their needs until they're able to be attributed to a primary care provider. The ultimate goal of this program is to reduce unnecessary utilization in the emergency department, as well as readmissions in the inpatient system. The financials in the bridge program, which is new for 2027, is we expect about $100,000 worth of net patient revenue and about $415,000 worth of expense in order to provide this service. The second service, which is new for 2027, is our Adolescent Inpatient Mental Health, or our AIM program. Again, SVMC answered the call from the state of Vermont when the RFP was put out, really to get the patient out of the emergency department and in emergency departments around the state and into a more appropriate inpatient setting. This is an extremely large clinical and administrative lift for SVMC as we launch and Dartmouth Health as we stand up SVMC's first foray into mental health. So we did step up. We did a joint feasibility study with the state of Vermont and are moving forward according to that feasibility study. This would not be possible without the support and the help that we're getting from Dartmouth Health. So this is just another example of how the integration with Dartmouth is helping Vermonters save money and have care closer to home. The anticipated financial impact for the AIM program, we are anticipating about $2.8 million worth of revenue and about $2.8 million worth of expense. As we've discussed in the past, and the feasibility was clear, that we are working to get a rate that covers our cost, and I'll talk a little bit about this a little bit later, which is an alternative payment model that we're currently working with the state in order to fully develop. I want to take 2 minutes and go through the summary financials of the budget. I'm going to work left to right on these columns. So the first column is our approved 2026 budget. Again, the major difference between the 2026 budget and the 2027 budget I just went through, but the major difference is 340B savings that we have full year in 27. The 2026 projected, you'll see, is very similar to the budget on the revenue side. Our net patient revenue is tracking very close to what we had anticipated in our budget process, and we are not expecting any major variances in revenue or utilization. You'll see that our other operating revenue and our expenses are both up. That is related to the 340B savings that we're receiving in 26 that we did not have in our budget. Our 2026 projection, we are anticipating practically a break even for the year. Finally, our 2027 budget, without the two new programs that I described, is presented on the screen to show an apples to apples comparison. Once adding the AIM program and the Bridge program, SVMC is expecting to maintain a break-even budget. I'm going to go into some of the specifics on the revenue growth and reductions percentages soon. With every budget comes risks and opportunities, so I really feel it's important to spell those out so that everybody is aware of those. First is locums expense. As we work to address changes to our medical staff, there's always the risk of needing to bring in temporary physicians and providers, and that comes at an expense that's typically more than when hired full-time. We do have some locum expense anticipated in this budget, but it's always a risk with unexpected vacancies. 340B eligibility is again always a risk. We won't. SVMC hovers right around the eligibility, usually within 0.1 or 0.2 percentage points above the eligibility. So it's always a risk that we will not meet it. On the opportunity side, SVMC is always looking to repatriate care for Vermonters out of New York and Massachusetts. This care will come back to the state of Vermont, not only provide local care, but also at a less expensive price. The 2027 benchmark set by the Green Mountain Care Board, we are reporting that we are within all of these benchmarks. First, the commercial net patient service revenue growth of -1%, as well as the commercial rate decrease of -1%. To walk through how we are looking at how we achieve these benchmarks. First, on the net patient service revenue side, starting with the 2026 approved commercial net patient revenue of $125.5 million. Then looking at the total fiscal 2027 budget commercial net revenue of 124.8. So this is a -0.5% when you look at our total 27 budget compared to our total 26 budget. If you look at the new services that we've added in the 27 budget in order to increase access that were not in the 26 budget, the Bridge program and the AIM program. First, the Bridge program, we're anticipating of the $100,000 worth of revenue, about $74,000 of that being commercial revenue. So if we back that out of our total 27 budget, that represents 0.1% of the commercial revenue. Similarly, the AIM program, we anticipate a smaller percentage being commercial revenue. We're anticipating the majority of this service being Medicaid, but the commercial portion of net revenue for the AIM program is just over $500,000 or 0.4%. So once we back out those new services, we achieve the 1% reduction in commercial net patient revenue through a 1% reduction in the rate that we are that we have from the commercial payers. We're keeping all of our charge master the same, so there was no increase in the charge master, and we'll achieve this through renegotiating the rates with the commercial payers. Growth in operating expense, benchmark set by the Green Mountain Care Board of 2.4%, has many factors going into this for SVMC. First, we looked at our business as usual expenses and services, looking at continuing the work that we've done on the efficiency side, looking at the variance of the 340B program that was not fully in the 26 budget, and finally the two new services. In order to achieve a 2.4% growth in expense, SVMC needed to reduce expenses by approximately $1.6 million in order to maintain our contractual relationships with our vendors, which have known increases more than 2.4%, as well as our anticipated increases to staff and benefit costs. So similarly, I'm going to walk through our expenses and how we are showing that we achieved the benchmark. Starting with the 26 operating budget expense of just under $230.5 million. Our total 2027 operating expenses represent a total 4.2% increase over that at just over $240 million. Included in that total operating expense is expenses related to our 340B program. So all this expense, this $3 million that is an additional expense, has offsetting other operating revenue. So we're treating this similarly to grant revenue, which has offsetting expense. I believe someone has taken over sharing. We'll try to retake it over.
That's back up now for us.
Great. Looking similar to what we did with the revenue side, looking at the bridge program, it is contributing to $415,000 worth of expense, and the AIM program just under $2.8 million worth of expense. So when you back off all of the new expenses that were not considered in the 26 budget, our total apples to apples comparison of services only has a 1.6% increase in our operating expenses. To achieve an operating expense growth rate of 1.6 has taken years of preparation and work in order to get to this stage. How did SVMC do it? SVMC is working extremely hard to limit our commercial rate growth. The major areas and I'm going to go through the major areas of what we're doing. The first is reducing administrative expenses. Over the 3 years since fiscal 2024, we've reduced our administrative expenses as a percentage of our total expenses by over 3%. This is a pretty significant increase and has taken a lot of work in order to get there. How we're doing it is a major area is our elimination of senior level positions after they have retired. At the end of fiscal year 2025, our Chief Human Resource Officer and Vice President of Administration retired. That expense has not been added back into the budget. For the 27 budget, we eliminated the controller position after he retired, and also the Chief Information Systems Officer and Privacy and Security Officer retired, and we eliminated that position as well. We are restructuring the Chief Medical Officer role. The previous CMO had many operational areas of oversight that we are splitting away from this position so that the CMO can focus on medical staff efficiencies and work directly with the medical staff. We've restructured the Chief Financial Officer role to be a Chief Operating and Financial Officer with executive oversight of many areas, picking up from where the retirements had happened. We are recreating a new VP of Ambulatory Services role. This role will be the administrative dyad partner to both the medical director of the practices as well as the chief medical officer. Their main focus and goal of this job will be to work on benchmarking and increasing access for our providers and for the community. This will also be the executive leader of the hospital outpatient services, working with lab, radiology, and the pharmacy. Finally, this is a reallocation of the controller position. We felt that the return on investment for this position for the organization as well as the community to increase access is better than having the controller position, and so we swapped out with a $0 budget impact. SVMC has implemented a productivity system in fiscal year 2024. This system measures the productivity of every department depending on using the number of hours worked for that specific department compared to the utilization statistics for that specific department. In 24 and 25, we really took a stepped approach into implementing the system. First step was to compare us against ourselves and our budget in order to ensure that our managers and our staff knew how to use the tools and were able to make the most impact. This year, we moved into benchmarking and looking at our peer hospitals and looking at each department and at their peer department level. This system is working. Through the 9 months ending June, we are 12 FTEs less than budget, which is about 10 to 12%, and about $2.5 million less in salary, contract labor, and benefit costs. Compared to fiscal 25, we are about 10 FTEs less than where we were in 1025, which represents about a $1.4 million decrease in expense. Again, this is all without reducing any services.
Bob, I'll take over here. And so just quickly, SVMC is investing in our clinical workforce. I want to highlight our nurse pipeline that has allowed us to welcome 22 new RNs to the organization this summer, and that's 22. We recruited these nurses to be out of our community with interest in continuing their education to become RNs. We paid for their education, including nursing school, and paid them to study. We actually, they're a full-time FTE for us, but we pay for up to 16 hours of time to study. And I think 21 of the 22 passed their nursing boards on the first attempt. This is working. This speaks to our process of investing in our workforce. And these nurses are in orientation as we speak. Next slide. Again, looking at what DH is doing as well in expanding care, what we're doing as well in expanding care with DH and local community partners, we've expanded access that we would not otherwise be able to offer to our community. One area that I want to highlight is our ability to provide inpatient dialysis for our patients requiring hospitalization. So to be clear, these patients were leaving the state if they required hospitalization. We have a quite robust ambulatory and home dialysis program, but until recently, inpatient was not an option because we do not have nephrologists on staff, or did not. Utilizing telenephrology from DH, we were able to hospitalize these patients at SVMC, keeping them in Vermont. Additionally, SVMC will begin offering fistula surgery. So again, these patients often require surgical procedures that have them leaving the state and going to Albany. And so our goal is to begin to offer using DH and vascular surgeons from Dartmouth Health to perform these surgeries locally and then be able to continue their care here while inpatient and then into our ambulatory or home dialysis program. Thank you.
Just to further on the Dartmouth Health and how we're viewing that as reducing costs, a lot of the administrative functions that are shifting to the shared services model of Dartmouth is really really has allowed us to be able to transform the roles of the senior leadership team and being able to reduce those FTEs. HR, finance, IT will all be moving to the shared services model. For 2027, the amount of support received from Dartmouth Health has increased, but overall, the allocation to SVMC has decreased. This is as a direct result from the work that's being done at Dartmouth Health and the overall cost structure bringing more value to the system at lower expenses, specifically in the pharmacy, quality, and supply chain areas. And I'm just going to move on to the reimbursement changes. So how is SVMC preparing for reimbursement changes? We are doing a lot of work in this arena. First is the Accountable Care Organization, ACO. So when OneCare dissolved, SVMC has signed up with another ACO. We feel it's extremely important looking at value-based care and working with a partner in order to be able to ensure extremely high quality of care, bring down the hospital spend for the Medicare population, and take advantage of the financial incentives from CMS in order to reduce the cost of care or the shared savings. Also, SVMC was an adapter of the Vermont Medicaid Global Budget. I had this in the slide prior to the dissolution of the global budget, but I really wanted to include it to show SVMC's commitment to transformation of the reimbursement models. Another area of innovation is the AIM methodology. We're currently working with Vermont Medicaid to develop a payment methodology for this service that aligns with the joint feasibility study. SVMC has made a public commitment to not make any profit on this unit. We've also committed to have an open books of this unit for the financials, so that way all of the direct costs of the unit are clearly visible, and so that we know that Vermonters are getting the best price for the service. We also committed to having a single rate for this service. So there will be no change in rates from Medicaid or the commercial payers. So we are working, like I said, we're working with Vermont Medicaid in order to finalize this methodology and plan to have reference-based pricing for this service at 100% of the Medicaid rate implemented into our commercial contracts. SVMC has done a lot of work in order to become leaner, in order to become more efficient, but we still recognize that the work is ongoing and we still have work to do. SVMC has submitted a response to one of the RFPs for the Rural Health Transformation Funds in order to be able to hire additional lean trained practitioners in order to have some pretty specific projects, to help with project management of some pretty specific projects. The anticipated cost of this grant is about $500,000 in order to bring these practitioners in, and we anticipate doubling that over 3 years in savings with the work that they're able to do. Finally, SVMC is working on our strategic plan in order to where we need to become over the next 3 to 5 years. This strategic plan is different than many traditional strategic plans. We're really focusing on the landscape of Vermont and the healthcare challenges that are present. We've developed these inputs to our strategic plan, just like the guiding principles of our budget. These are what's guiding our strategic plan. As you can see, most of these, all of these are tied back to the financial feasibility of SVMC in Vermont in reducing the cost of care and being able to succeed and increase access at the same time. The healthcare financial situation of Vermont is forefront in our strategic planning process. As Dr. Garcia mentioned, we are meeting with many external, our consultants are meeting with many external stakeholders in order to make sure that our strategic plan fits and is complement to all the work that the state is doing. Just want to highlight our cash and capital budget anticipated needs for 2027. For days cash on hand, we are anticipating for SVHC to have about 173 days of cash on hand at the end of 2027. Well, that sounds like a lot of cash and a lot of excess cash. SVMC is one of the oldest, if not the oldest hospital, and has a lot of needs in order to that have been deferred maintenance over the years in order to build that cash balance up. In addition, we still have a line of credit coming from the COVID era when our operating expenses were misaligned with the revenue of $22 million that we need to start paying back in order to reduce interest expense. After that $22 million line of credits, $50 million in the master facility, which is just to replace our aging facilities. Our cancer center, our Epic upgrade, and routine capital all contribute to cash needs for 2027. Looking at our routine capital, we are expecting about a $7 million capital budget for fiscal 2027. Having a break-even operating margin will make this difficult, and we will need to go into our cash reserves in order to do this, but we are going to need to do it in order to continue to modernize and maintain our facilities. That $7 million, we're anticipating it being allocated to information technology for the lion's share of it. This is in order to modernize as we get ready for the Epic integration. Clinical equipment and facilities that have had a lot of deferred maintenance over the last 10 years. are going to need to be replaced, and we have a $1 million contingency for items that we are unsure of at this time. We also have 3 major CON projects underway. One, the adolescent inpatient, the AIM unit, our cancer center, which was approved in July of 2025 and is currently under construction, as well as our electronic health record replacement, which we just received our CON approval yesterday. So that was our prepared remarks. I'll open up to Esteban if you have any final closing statements. I'll open it up to questions.
Thank you. Thank you, Bob. Chair Foster and the board, we look forward to answering your questions. And again, as we move forward as an organization, I think our partnership with you is really vital for us as an organization, and our future is really is together with the remainder of Vermont and healthcare in Vermont. So we look forward to the conversation. Thank you.
All right, thank you very much for the presentation. I'll turn to Member Merman for any questions he has.
Great, good morning. Thank you. Dr. Garcia, it's nice to meet you. Welcome, I'm Dave Merman. So I'm one of the 5 board members. I'm an emergency physician up in this part of Vermont, but I trained in Boston and went to med school there and did a first and second year clinical, like, one of those early clinical rotations in ID at the Shattuck, as well as my third year psych rotation at the Shattuck. So I know the Shattuck and the public health hospitals in Massachusetts very well. And I think that, or just that one actually, but I think it's an impressive system. It's incredibly hard work. This is the safety net of the safety net. And I think sometimes we talk about safety net care in Vermont, but it's really quite an amazing dedicated workforce and patient population with incredible needs that, from my experience, was really treated with incredible respect and humanity, including a large prison population, which I think sometimes providers have challenges with. So anyways, I just want to give that background and welcome you here. And I'm very glad you're here. Okay, so I have a bunch of questions. Some are from this quick presentation. They're quick questions, kind of one-off things from the presentation, but I don't remember seeing the inpatient dialysis numbers in the submitted materials, but can you give an idea of sort of how many patients you're admitting with the inpatient dialysis and how that is going? I know that was a big lift over the last couple of years.
Sure. So I think we admitted, we just reviewed our annual admission numbers, and I think we are over 50 admitted patients. And again, we limited it initially to our own dialysis patients so that we were able to, and the way we do dialysis is interesting because we've got the ambulatory dialysis unit, and so it runs 6 days a week, two shifts, the morning shift, the afternoon shift. But in addition to that, we do home dialysis, and our nephrology service is actually out of Massachusetts. So Berkshire's helps for our ambulatory services, but they did not have capacity to help with inpatient. So when we went to inpatient, we did teleservices with DH. And because we have a different EMR, we had to train all of the nephrologists at DH on our very old EMR and have them have direct access and document within that EMR. So we have over the year, so June to June, this past June, about 50 patients, very successfully done, and but they were all our own patients. Our goal moving forward is to be able to answer the call across the state for an admission for a patient on dialysis to be able to come here, and even if they're not our own dialysis patient, we just wanted to make sure we got all the kinks out before we started bringing patients from other parts of the state in. But that is our goal this next year.
Great, thank you for that. Which ACO are you contracting with, or is it still up in the air?
No, we are contracted with Belong Health.
Okay. Okay. So Robert, this may be for you. With regards to Act 55, you have decreasing revenue secondary to the ASP cap, but increasing revenue, I believe, secondary to the contract pharmacy. Do you have a breakdown of the revenue gain from the contract pharmacy versus, in it, and so we can kind of understand the balance there between the revenue lost from the ASP cap?
Sure. So we've been running the figures, trying to calculate our impact from Act 55. Because of the way that we post our explanation of benefits, we are not able to, our payments. It's very difficult without looking at every EOB in order to determine the correct payment. But from our updated estimate, we are tracking at what we reported last budget at a $9 million annual decrease in revenue related to Act 55. The increase in revenue from the contract pharmacy piece is not recorded in our net patient revenue. That's recorded in other operating revenue. So it's not commingled with the effect of Act 55. So that is about $6 million more than last year's budget.
Okay. All right. Thank you. So I just trying to understand your relationship with Ovation Healthcare. It sounds like maybe you're not working with them currently, but this Vermont healthcare landscape document, I think you brought it up in the hearing on a slide, looks like it was prepared with Ovation. So I'm just trying to figure out what is the
Sure.
relationship with Ovation?
Sure. They're our consultant we launched our strategic plan just this month. And they're our consultant that is leading our strategic planning process. It's about a 5 to 6 month process, but we have already begun. They were here. They've had multiple conversations with individuals across the state. I think AHS and others they've engaged with. We asked them to please reach out and speak with with leadership of the state as well.
Okay. All right. So actively still contracting with Ovation on services.
Yes, for the next probably 4 months.
Okay. Just a semantic thing that I've been struggling with through these hearings, and I haven't asked anybody else yet, but when you say 340B savings, do you mean 340B revenue?
Yeah, I mean 340B, it's savings that we receive by purchasing drugs at a reduced rate. So it's less expense than we're paying for the drugs.
And then you sell those. So then is that different than the revenue you earn off of purchasing 340B drugs and then selling them back? Or are those, yeah.
So using our infusion center, for example, the revenue from infusing the drug was reduced by Act 55. That has nothing to do with 340B. The 340B impact is we're able to purchase those drugs in order to be infused into the patients at a reduced rate because of our rural status.
Okay, and then what about the retail pharmacy component? Then?
On the contract pharmacy piece of the program, so we contract with outside pharmacies, and we purchase and replenish the drugs at a reduced rate, and we receive so that piece, I guess you could say, is revenue. We do receive cash related to that in the program.
Okay.
Dave, can I ask one question? So sorry, when you say savings on 340B, you essentially mean margin.
No, savings meaning if we were not in the program, we would have to purchase the drugs at our GPO prices. Because we're in the program, we're able to purchase at a reduced rate. So it's less expense. We save an expense.
And is the amount you're saving equal to, so the amount you're saving is not equal to the delta between what you receive for it and what you pay for it?
Correct. That's not the calculation of the 340B savings.
Got it.
The savings
Okay,
is
thanks.
calculated based on what we would have paid for it versus what we did pay for it.
Understood. All right. Thanks, Dave.
Yeah, okay, so just to clarify then, so if Act 55 didn't change the regulation around contract pharmacies, would you still, like, did this change the amount of, I guess, is your volume of medications that you then contract with increased because you can purchase them at a lower price?
Act 55 didn't have effect on our contract pharmacy, but so that part of the program is separate. Act 55 reduced the revenue that we receive from infusing the drugs pretty much in our infusion center, on our outpatient clinics. So what happened was the revenue that we receive from the commercial payers for infusing these drugs dropped to, in some cases, below what we pay for the drugs. It's not related to our contract pharmacy business. Because we
I guess
purchased the drug.
I thought there was a component of Act 55 that dealt with, I can't remember the entire details with it, but I thought it changed how you could contract with contract pharmacies, thus allowing hospitals to have increased revenue through using the 340B program to eliminate some of the barriers to the pharmacy, the contract
there was
pharmacy.
There was some language that attempted to allow hospitals to maintain the contract pharmacy business, but it did not impact. I don't believe it impacted the financials for that. I'd have to go back and double check, but
okay, I'm a little bit beyond my understanding of that.
The major impact of Act 55 was on our outpatient services provided at the hospital and the drugs that we purchase. That hospital purchases to administer at the hospital in our outpatient clinics.
I was just trying to figure out this other component of it, but thank you. Okay, so there was some discrepancy in the submission, but I think it was corrected in the RFIs about the ED physician expense. And I think if I'm getting it right, it actually was 6.8 million in 26 and 6.6 million in 27 budget. It originally looked like it was about 4 million and it was going up by a large percentage. All right. I just want, it's not, are the ED physician expense going up by 20-25%, or is that like okay?
It was an issue with the original submission, correct?
Okay. And then before I ask my next question, I just want to lay some context of this, because I'm going to talk about RVUs, and I feel like we've been talking a lot about RVUs and productivity, but I just feel like I need to sort of share some thoughts. This isn't directly a SVMC thing. This is this is throughout the process. But I do think when we talk about measuring clinical productivity, I think this is a very complicated thing. What do we want our providers to do? What do patients want? What does our system, what does our community want when they visit a doctor or an APP? What benefit does an employee have to an organization, and how do we value the contribution of all these different things of employee benefit? And so, and then, we had this big statewide attempt at value-based care. I think for with One Care and the ACO, and my experience in looking at this is that it was challenges of still trying to figure out how to evaluate provider productivity in a value-based care model. And now we're sort of, and I think we've been concerned about access and reduced access to care and some productivity issues at various places. And so I think we've kind of migrated back to using this RVU, or relative value units, to try to measure productivity. And so just to speak out, and most of you know this, but the concept of an RVU is it measures work effort, but they're very biased towards procedures. And I think that they have a relatively meaningful estimate of volume, especially in the clinic setting, where each patient is getting a very similar set of services. But they don't sort of bring in all that sort of other work that providers do. So I think overemphasizing RVUs can potentially kind of change how treatment is provided. And I just sort of give an example, and Troy's not here this year, my EM colleague, but in emergency medicine, there's a huge amount of judgment of whether or not to code a patient as a level 4 or level 5, or to bill critical care time, or when you use an ultrasound to aspirate a knee, or bill that ultrasound separately. And all that really impacts RVUs without really impacting quality of care, the services delivered and whatnot. And I think when we think about other fields like education, do we want our teachers to be solely valued on the number of students they educate? Should we increase our class sizes to 40 so that our elementary school kids, teachers look like they're more productive? Or do we want them, are we trying to measure something else? Or in higher education, is it grant funding? Is it publications? Or do we think there's something different with education? So I just give all of that background because I think we just I feel like I just need to lay it out there that I think this is complicated and our views are flawed, but at the same time, there's sort of the national standard by which we're using to measure productivity and to sort of benchmark, how much work providers are doing, but in this incredibly inherently flawed way. So with all that long caveat, I did not see the emergency medicine clinical productivity listed in the clinical productivity worksheet. And I was wondering if you could provide that information separately at some point.
We can look to see if that information is available. Our emergency room physicians are measuring on productivity. We don't measure our emergency room physicians on productivity because of the fact that the factors that you just mentioned, as well as the irregular, they don't schedule their patients, unlike, they don't maintain a list of scheduled patients, but I can look to see if we can provide that.
Okay, thanks. And then the one last question I have is, and this may be a reporting thing, but in the adaptive staff FTE workbook, there was 23 clinical FTE in your medical group administration. It seemed like a large number of clinical FTE in the medical group administration for a hospital your size. Can you explain that? Or
Right, included in there, we have clinical staff that work at multiple locations. So rather than allocating the clinical into each location, it goes into administration and then allocated out a different way. So our annual wellness nurses, for example, they work at all of our primary care locations. So instead of having a timed allocation of each practice that they work at, we code them to the medical staff administration, the medical group administration.
Okay.
It's a reporting because of our systems, the limitations that we have in our systems. It would be an inordinate amount of work in order to track. So that's how we've handled it.
We do not have that many clinical administrative positions.
Correct. Correct.
Great. Okay. That's all I have for now. Thank you.
Thank you.
I think I'm up, Chair Foster.
It's me.
Oh, it's you. Okay.
You're welcome to go if you want. Do you want to go? I only have a couple. On one of the slides, you mentioned that the 195 million RHTP fund is to move care out of hospitals. What care are you targeting to move out of your hospital?
Right. A lot of the work. Go ahead, Esteban. Go ahead.
Well, I was just going to say that this is where we are looking to see how it's not even moving out of the hospital. It's preventing entrance into the hospital. So what we're really looking at doing is trying to strengthen our primary and preventative care so that we can keep patients healthier and keep them out of the hospital. And what even looking at the bridge clinic, the idea there is that they're coming out of the ED, the hospital, or urgent care, and they don't have primary care. They will end up back in the ED, back in inpatient, or back in primary. And so what we're trying to do is by using a provider who can review their medications, check in on them, make sure that they were able to pick up their medications, and then follow them up in person, keep them from that next visit. So my goal is to really start upstream and to prevent illness that requires hospitalization. That's really what we're doing, and that's what I hoped I tried to say about that. Kind of my shift here at this organization is really leveraging and leaning into primary preventative care to keep patients healthy and out of the hospital to begin with.
And what targets have you set for reducing hospital revenue as a result of those efforts being successful?
So we're in and I guess, Bob, I don't know if there's a specific number. What I would say is the strategic planning process launched last week and this week. And so we are looking to try to build how to build this to work. And so we're still in that early stages, but I don't have a specific target yet. Bob, I don't know if there's anything that comes to mind.
I mean, what we have done in the budget is we have left all of our ED visits and inpatient visits flat, even though we know that our population is aging and that will potentially require additional services. So I think that bending the curve and keeping it flat is our goal.
Has there been or are there plans to do any modeling on the decreased revenue to SVMC as a result of this effort to move to preventative care?
Yes, we are, as Esteban mentioned, we're currently working with the strategic planners in order to do that.
Okay, great. As you develop that, definitely send it to the board. We are looking statewide, as you know, to reduce hospital revenue and hospital-based care. And there's going to be a financial crunch that's coming, and understanding how that will be accounted for is important. In your submission, you indicated there was no projected increase for Medicare or Medicaid revenues. For rates. Do you have any update as to any expectations for increased Medicaid and or Medicare rates?
We don't have any hospital-specific update yet. We are, working with our reimbursement team in order to determine this. With the potential increases in the proposed rates for Medicare, there are many other factors that we are currently crunching to make sure that they don't offset those potential increases. So for this budget, in order to be conservative and not increase our expenses for revenue that will not be there, we left the revenue rate consistent.
What are your current expectations for an increase in Medicare reimbursement rates?
In the budget, we left it at flat.
Outside of the budget, just you sitting here today, do you have any expectation as to any increase from Medicare for rates?
Without the full picture of wage index changes and all of the other different factors that go in, I don't have any further estimate over what we have in our budget.
And by when will you know the outcome of potential increases in Medicare rates?
Typically, we learn about that in the at end of the third or early fourth quarter of calendar quarter.
And it sounded like you were alluding to potential offsets if there were an increased Medicare rate. Can you walk me through what those would be?
When we developed our budget, I did not want to assume. We wanted to make sure that we're conservative enough on our revenue in order to not overextend us, so that we don't have any offsets planned. We don't have any offsets planned if the Medicare revenue rate increases.
Okay. If the Medicare rate were to increase, let's call it 3 to 5%, how much additional revenue would that be approximately?
I'd have to calculate it. I have not run the modeling at that level.
I had a lot of confidence in your mental math on the spot.
Right. I don't want to say under oath. I don't want to say a number that's wrong.
Understood. Is there any reason, if there is a Medicare rate increase, that we should not decrease the commercial prices by a commensurate amount to improve affordability for your patients?
I think as we look at what any kind of rate increase, I think that it would be more beneficial to reinvest those in increasing access to care in order for the long-term goal of reducing healthcare costs, like Dr. Garcia mentioned. I think it may be short-sighted to remove that for this year in order to handcuff us from what we're able to ultimately achieve, which would have year-over-year savings and increased access. So I would ask that we take a look at the bigger picture rather than just the fiscal 27 impact.
Fair enough. And just to probe on that a little bit, there seems to be baked within that a presumption that those monies should be reinvested in SVMC rather than Vermonters having more affordable care and or those dollars being reinvested in another part of our healthcare system that's not SVMC.
That's why I said we should look at the bigger picture and evaluate. But yes, my view would be to reinvest in SVMC for in order to take care of the patients in Southern Vermont.
Okay. And, where we sit, our job is to consider where those limited healthcare dollars would best be spent. So why, in your view, I'm going to presume there is going to be a Medicare rate increase. Some hospitals have budgeted it. We see it pretty much every year. If we allow it to go to SVMC as opposed to the commercial ratepayers in your community and or other providers, mental health providers, independent primary care providers, everyone else, what is your best argument as to why it should go to SVMC as opposed to the people paying the bills and or other healthcare providers?
Well, I mean, I'll speak up here. I think that it should go to SVMC because of the process we have undertaken in order to expand access to primary care. We are the primary care provider in our community. There's a very small FQHC in the community. It doesn't really touch the primary care needs in the community. We provide primary care in 3 states. I mean, I know that's not for discussion here, but or in 2 states anyway. And so I think for what we need in Bennington, SVMC knows what we need in Bennington. We understand that, and we need integrated primary care with mental health. And so we would welcome the opportunity to continue the expansion to meet the needs of our community. We believe we know what the community needs.
And why should it go to SVMC to do that rather than the FQHC and expanding access through the FQHC?
Again, I mean, the FQHC probably has their perspective on this. I think that we can utilize the dollars to expand primary care where primary care needs to be expanded in the community. We know where that need is and could certainly use those dollars to be able to expand that primary care. I just think we know what the need is of the community. We have a 100-year legacy here, and we currently provide, I don't know the number, I'm under oath, but the vast majority of primary and subspecialty care in our community. I mean, I think we do it well, but we have access challenges.
And look, these questions
Chair Foster, may I just add a comment from the board perspective?
Please.
Our top priority here is growing access, which feeds affordability and sustainability. And we are growing a primary care workforce. We just had our gala, which is a once a year event, raised $1 million for the family medicine residency program in one night. And we are the ones growing the primary care workforce. It's not the FQHC. Their volume, again, we love them. We partner with them. We want to do more work with them, but they don't really cover even a very small number of days of what we're doing every day. So that's just not really the alternative. Again, not negative, good partnership, but we are the ones that, with Dartmouth's help, we could never do this. We could never be a community teaching hospital without Dartmouth, which runs 50 residencies. We're starting the very first residency in family medicine that Dartmouth as a system has, and only the second one in Vermont. And so we are the engine of the primary care workforce. So that's that to me, just at a board level, admittedly 60,000 feet, that's why it should go to SVMC.
Thank you. And look, my job is to probe these assertions and to challenge them, and I have to make the decision with my board members. And so we need to ask these questions. And,
Sure.
SVMC has been a hospital that we have really, I personally, and I think the other board members have really respected a lot of what you've done and how you've presented your budgets with us. So please don't take my probing in any other way other than I have a hard job to do. And these dollars are statewide. And we are very concerned from a macro perspective of consolidating our healthcare dollars in hospital care. The SQHC and any independents that could ever come there will provide primary care more affordably. They just do. So these are reasons why I'm probing it, and I appreciate the answers very, very much. Shifting gears just slightly, workforce can you, I think you gave it to me, but I don't have it in front of me. What is your year-over-year increase or decrease in locums?
Sure, 1 second. I'm gonna pull that up. Our locum expense is expecting to increase about 300 from our continuing operations, about 300,000 over our current run rate, and about 800,000 over our current run rate. So our 27 budget has locum expenses of $4.8 million.
And do you know, let's say a total number of locums associated with that 4.8 million. How many locums are you relying on?
I would have to get the actual FTE number.
Yeah, it varies as as the nature of locums, it varies month to month and service to service. So yeah, we'd have to get the numbers.
Sure. Okay. One of the issues that came up in the medical center at UVM's budget is the amount of financial support going from Vermont commercial payers to finance the Larner Medical School. Have you had conversations with Larner and or UVM about filling your provider gap and strategies to ensure that more of those providers being developed in Burlington are coming to Southern Vermont?
I certainly haven't had direct conversations with them about bringing providers into the community, but when we are recruiting, and I meet everyone that we recruit across the organization, at one of our family medicine spots that's open, we have a senior a senior resident that's interviewing from the UVM system in family medicine. So certainly we look to the kind of Vermont first in our recruitment efforts to fill positions. We are a different, you really do have to want to work in a rural community. With all due respect to UVM, the training program is not a rural training program from my perspective. I've run residency programs and fellowships in New York. I totally understand kind of the difference between an urban program, urban and rural, and we really are a rural community. You have to be willing to do quite a bit for your patients, and it's a different animal. So that's the reason we're looking. So we look to UVM, of course, because they're at least within the state. They understand Vermont, but we also look to other rural training areas to see if we can recruit folks who know what they're getting themselves into when they come into a rural community to do family medicine and other services. But yes, we work with them, but I haven't spoken with them directly about the issue.
And you're in a wonderful rural community in a wonderful part of Vermont, I will add. Here's the point of my question, though. You have a need for more providers. It appears as though out of the Larner graduating class, about 35-ish or so providers out of 120 stay in Vermont annually. You need more providers. What can be done to get more of those providers that are graduating from Larner to your hospital? And what strategies need to be put in place? And what can you do to work with Larner and UVM to make sure those providers are staying here in Vermont? Because the Vermont, to my point earlier about giving you the commercial money as opposed to somebody else, the board is also potentially deciding to allow UVM to spend $50+ million on the Larner School of Medicine. That money needs to help Vermont as much as possible. Those dollars have to go as far as possible. So I will put it out there as an ask of you to ensure you're having direct conversations with them and targeting how many providers you need and where that medical school can help fill that gap. I realize these patients have, or these students have a lot of opportunities and volition, but I want everything done so that we're not having $5 million a year in locums expenses when we're when 90 students are not staying here and going to a wonderful place like Bennington, Vermont. So I'll just leave that there because I think it's really critically important and can help solve some of your financial problems, and something I want information from you of what we do as a regulator to watch that 50 million that's going to help ensure that all of our hospitals in Vermont are getting the benefit of those commercial dollars.
I agree, and I will take that on. I'll just use one example. When I was at Cooley Dickinson, I personally went to Brown looking for rural OB family medicine providers, and was able to meet all of their providers. We developed a relationship. We were able to recruit right out of their program. I have not done that yet here. Our chief medical officer will be here in the next 2 months. Today, I am in 2 roles. And so I'll be happy to have the chief medical officer who's from Vermont begin those conversations. I think that's a great idea. Thank you.
Great. I want to see those numbers spike. I want to see those people staying in Vermont. Like, they need to spike. And whatever we can do from the regulatory perspective, I will take that feedback for the board to consider.
Great.
And I mean now, like during our budgeting process, because that has got to jump. Last question, you spoke about repatriating care. Some of your services might be cheaper. Some of your services are more expensive than out of state. Are you targeting repatriating care that is more affordable, or just all care that you possibly can? I'm recognizing there's access and availability issues there, but I want to make sure that you're thinking about repatriating care that actually is more affordable for Vermonters to get at your hospital as opposed to more affordable elsewhere.
Yeah, absolutely. Absolutely. Access to data is always a challenge to determine exactly what those comparisons, but we are working with less staff in order to try to make those comparisons. But yeah, absolutely. We want to reduce, we're very committed to reducing healthcare costs for Vermonters, through all of the work that we're doing that we just presented. So we want to bring care back to Vermont where it's going to, for the whole healthcare system of Vermont, be beneficial. That's our goal.
Right.
Okay. That's the way that SVMC survives. That's the way that the state of Vermont survives, and that's how we're viewing this work.
Agreed. All right. Thank you for your presentation. And Mr. Green, I always appreciate when board members attend and participate. And Mr. Garcia, thank you for being here. Dr. Garcia and Mr. Laba, really solid budget presentation. Your hospital does great work. And I thank you for your time and letting me indulge in my questions. And I'll turn to member Teach out.
Thank you, Chair. I just want to say to your last question, you wrote a tremendous order approving our cancer center, which we really appreciate. And that's one example where your own order shows how much less expensive, we are compared to Albany and some other places. So appreciated that document. I have shared that with a lot of people. And I think we're going to show the same thing in cardiology, where we just added a second CAT and hired an interventional cardiologist for potentially down the future road, expanding that effort, which would be, again, less expensive than Albany, where we see most of the outmigration and those services as examples going out of state to more expensive places. So appreciate that last question and the opportunity to be here today.
Yeah, thank you. Very good point. All right, member Teach out.
Great. Good morning, and thank you for listening to my questions here. I did have a question about anesthesia, and maybe I just didn't understand, but there was about 20% drop in expenses, and I didn't understand what was happening or if you're outsourcing in that area.
Right. So that is, I'll have to go back and look at the details on that. I believe there was an issue with the presentation of the 26 budget, but let me take that as a follow-up to get the exact details on that.
Okay, it's in the expenses by department sheet that you submitted.
Right. I think there was when we were filling that out last year, when we were filling out this year, we recognized that there was an issue with the way that it was filled out last year, but I will take that as a follow-up. There is no
outsourcing.
Material change in the way that we're running anesthesia. So
Okay.
I believe it was just a reporting.
Okay.
Misalignment.
Okay, that'd be great. On page 9 of your narrative, you talked about the arrangement with the Battenkill Valley Health Center to have diagnostic services at your facility. Is that a new arrangement?
No, we have, that was just an example of where we are working with community partners.
Okay. And then on page 12, you talked about your own employee health benefits and expenses. And I had a few questions about this. Did the way you offer employee health benefits change when you became part of Dartmouth Health? Or are you offering this separately?
Yeah, so these, a lot of these that were mentioned on like the housing and daycare, those are all before Dartmouth, and those are continuing now that we're a member hospital of Dartmouth. As part of the integration, we will be moving to the system benefits platform in January of 27. So this budget year, and all those costs have been factored into the budget. So we will be under one Dartmouth medical and dental benefit plan.
Okay, and does that include health insurance benefits?
Yes.
Okay. So you talk about the home network discounts with lower deductibles. Is it also lower prices?
We discount our prices for our home network, yes.
Okay. And then it says you have free care for your employee health department clinic for minor illnesses such as strep, flu, COVID testing. So your health insurance plan pays for that, but you don't charge the employee?
The employee goes to our express care location and is able to see a provider in our express care location through our employee health program.
Okay. And then
So
it's not billed.
It's separate medical record from, and our employee health records are separate from our billable patient records.
Okay. Okay. And then, okay, I'm going to switch now topics to your contracting with commercial payers. How many payer contracts do you typically renegotiate annually?
We typically renegotiate when the budget orders come out in order to make sure that we're in alignment with the budget orders. We have very few commercial contracts compared to where I came from in New York, where I had many contracts negotiated every year. So it's
okay. And it sounds like you're not planning on changing your charge master, but you're planning on negotiating contracts to achieve the guidance that the -1% for commercial.
Correct. SVMC is committed to reducing the rate that we're paid for the same services in order to achieve the guidance, the 1% reduction guidance.
Okay, and do you intend to target any one area of your organization? I noticed in I'm only talking about the publicly available pieces of your rate decomp sheet, but it showed that, and I might be mixing utilization and price, but you had a 3% increase in major commercial for professional services, a 0.6% decrease for outpatient, and a 14.4% decrease for inpatient. Those were sort of the rolled up numbers, I think. Is that how you're planning on applying the guidance?
We're planning on increasing our primary care access. So that I believe that is the showing of the increase there for you in utilization on the professional side. And then because we want to take as much resources that we can from the hospital into the preventative primary care side. So we anticipate focusing on the hospital outpatient and inpatient arenas for rate change. Okay.
That would be good because I noticed when I was looking at our comparison tool that overall your hospital has the third highest prices of all the hospitals in Vermont and the fourth highest for outpatient services. It was less for inpatient. And then I think my last question was around your revenue cycle improvements that you discussed on page 6 of your narrative. And I think so it sounds like you're planning on improving how, getting more fully paid for the services you're already billing, not upcoding or billing in a different way is what it sounds like. You said further reduce medical necessity and timely filing denials.
Yes. So our revenue cycle team is under transition right now. We have a new leader who just started last week, and anticipate better reporting and in order to and better monitoring of our bills in order to reduce those denials. We are also investing in technology in order to help with our authorization process, and with that, anticipate being able to reduce the administrative burden on our staff, so that those staff can help with scheduling in order to increase access and be really redeployed into other areas rather than on the phone with an insurance company. So we're making significant investments in our revenue cycle, significant change in our revenue cycle, not really a lot of dollar investment, but investments in order to improve the revenue cycle process to be more efficient.
Okay. And then this was listed under opportunities. So is this something that you see as a positive upside, but haven't necessarily budgeted directly for?
Correct. We did not. It's an opportunity because but if we are able to implement this, we'll be able to have an opportunity to have further reduction in expense than what we've already taken.
And further increases in revenue?
Reductions in denials, right? If we're able to get billed if we're able to get paid for the work that we're providing and not denied on a technicality of missing a deadline, yes, I feel that the hospital deserves to be paid for for the work that they do. So we need to we can't make missteps on not getting an authorization when the insurance company requires that, or filing a bill late. So yeah.
I agree with you. I would like your hospital to get paid when it's appropriate. Okay. Great. So I think those were my questions. Thank you.
Thank you.
Can I pop back in just for a few follow-ups from the last two people? Is that all right for whoever's next?
Go ahead, Dave.
So I just want to sort of go back to the price thing that Chair Foster started and Member Teachout followed up. This kind of gets to the question of whether or not, if every other hospital that I've reviewed at this point, and I must double check my notes, but has budgeted a Medicare price increase for the year. If that holds and Medicare increases their reimbursements by 2%, given that you look to be the third most expensive hospital in Vermont, again, understanding that information, does that change your view about whether or not that Medicare revenue should be offset by a commercial price reduction for the standpoint of affordability secondary to your high prices, especially, that's.
Yeah, I understand your position, and I feel that work that we will do will drive down the cost for Vermonters. I'll have to formulate a more formal response, I think, for that. In theory, I understand what you're saying.
Say Medicare increased their reimbursement by 10%. Would you still hold the same assessment that SVMC should continue to receive the third highest prices in Vermont in order to then invest on preventative services to long-term drive down the price of healthcare in Vermont?
Well, yeah. What if we're successful and we reduce utilization by 100% or by 80%? Yeah, I think we still have to provide those services. So it's very much more of a complicated math problem than just saying if we get 10%, we can reduce commercial rates by 9%. It's a much more complicated than just swapping this for that, because there's utilization, there's service mix, there's a lot of factors that go into to running a hospital. So I think I need to take in order to come up with a definitive. I don't want to go on oath committing SVMC to something that I'm not fully thinking all of the different factors through.
And I appreciate that. This is just more of a, honestly, a theoretical conversation about how we manage weighing these various factors, because for a long time, and I would have to go back and review SVMC specifically, but generally speaking, there's been the sort of the cost shift argument made by most hospitals, such that if Medicare under reimbursed, that should be made up for by commercial getting reimbursements going up. And what I'm asking, I guess, is if the opposite, if Medicare does reimburse higher, could commercial reimbursements go down? Or once we're shifted and it's set, like you can't undo it.
If we receive adequate reimbursement from Medicare that fully paid for the services that we provide in a rural community at the scale that we're able to provide them, in theory, the commercial rates would be able to go down. We're not at the point where that's happening. SVMC is making every effort in order to become more efficient, in order to reduce our expenses, in order to get to that gap in both directions, one from the revenue and then also reducing expenses in order to make that happen, but we're not there yet.
The other area that I just wanted to follow up on is, Mr. Green, you mentioned that this will be the second family medicine residency program in Vermont, but I don't know if you, as board chair, are aware of the work on the Maple Mountain residency program that is being run through some federally qualified health centers in Vermont. And if your team at SVMC has been at all able to work or collaborate with them on, I'm not saying efficiencies in delivering, but efficiencies in sort of getting a rural family medicine residency program off the ground in Vermont.
Yes, we
Both
do know
exciting,
about that.
yeah.
It is very it's very new. My understanding is they launched just this July. There's been a lot of work going into it up to this point. It is a very different model than our model, right? Ours is going to be hospital based and supported. Theirs is certainly consortium so it's a different model. But absolutely, we will learn from anyone, and both I think Maple Mountain and their leadership, and I am speaking at the VOS meeting in September to talk about approaches to residency training programs, moving forward in the state, and two options: one kind of consortium based and one hospital based for others, hopefully to learn from each other.
One thing that I'm not deep in this, so I don't know the numbers particularly well, but my impression of the cost of getting at least the Maple Mountain program off the ground was in quite a bit less, 2.5 to 3.5 million is my recollection, and I think you guys had noted 20 million at some point. It would be worth sort of trying to reconcile those different numbers to try to, clearly you're doing different things and maybe those are the costs, but it seemed as if, and maybe they're allocating different costs than you're allocating and different potential revenue by having residents seeing patients and whatnot. But it's something I think that it would be worth reconciling if they have some ways to do this in a more cost-effective, cost-efficient manner. That would be helpful. But thank you.
Member Holmes or Walsh?
Go ahead, Tom,
Okay,
if you want.
thanks, Jess. Good morning, and thanks for the what I thought was one of the clearer presentations that we've had. And thanks for the work that you're doing. I really appreciate the effort that you've outlined, the focus that you bring, and the success that you've had in reducing your administrative expenses over the past few years. I think you can tell by my fellow board members' questions about high prices that the expenses have to come down because the prices are going to go down. And so it's apparent that you see that. And thank you for it, and thank you for the work that you're doing. In a couple of your slides, you described the Bridge program and the AIM program, and they're forecasted to be operating at a loss for some time, if I remember those numbers correctly. One of them was not a very big loss, but still a loss. How long until those programs break even?
So the AIM program is forecasting and budgeting to break even. So that work with the state in order to reduce those expenses, in order to have a lower rate for that program. But we're based on the feasibility study that we did with the state, is to break even. So not make any money, but not lose any money. On the bridge program, this is an investment that we're making to further increase access to primary care. So this program is really focused on only seeing patients as they're discharged from the ED and the emergency and the inpatient unit in order to get them into a primary care practice. At this first year, we're budgeting to lose about $300,000 in that program. It's a very lean program with one APP provider and very few support staff associated with it. But we're hoping to. It's a program that's designed to not keep those patients. It's to bridge them from their ED visit until they can get in with a full-time primary care provider. So it's always going to be seeing new patients, and so you're not going to get the efficiencies that you do when you're seeing a provider for 20 years. So, but it's an investment that we feel will ultimately reduce hospital utilization and allow us to reduce our expenses and be able to charge less.
And the evidence around that type of approach, finding the high utilizers, finding the frequent flyers, all of that's pretty positive and does go in the direction you're aiming, no pun intended, but that's what we're trying to do. So certainly if Medicare reimbursement were to go up, it may be difficult to forecast how much prices could come down, but could you commit to making sure this new cost control program grows?
Yes, we are fully committed on making SVMC more efficient and transforming for the payment reform that's looming. We fully expect the way that we're paid for our services to change in the next year or so, and we need to be ready from an efficiency standpoint, and are 100% committed to that.
It's a very community needs focused intervention. I appreciate that very much. We can see it from your CNHA. And so, yeah, it just seems to make sense to me if that is the type of focus you're bringing, and Medicare reimbursement were to come in higher than budgeted, that filling any gap in those type of programs would be aligned with the priorities that you've outlined before us.
Right. My hope would be to spend that money on more transitional care nurses to go out into the community to work on those high utilizers. More money on when the bridge program gets to capacity, add another provider in order to be able to service more of those patients, because the $300,000 that we spend on this program will have we could spend that very quickly in the emergency department. We will save that multiple times over. So I feel that reinvestment in the work that SVMC is doing will have a multiplication effect. And I think that our strategic way of thinking and it's the way that we're doing the strategic plan is much different than other strategic plans, shows our commitment and our ability to utilize these funds would be to utilize those funds for the greater good of Vermonters.
Thanks. Your presentation showed some meaningful reductions in administrative expense. I mentioned that at the outset. The overall trend, looking back over previously submitted budgets and your Medicare cost reports, and even with the guidance that we provided this year, has been for operating expense to grow faster than revenue. That builds an unsustainable system. and you've started to correct that. Are there one or two measures that you're using that tell you how far you need to go, or things that the board should monitor to understand if the improvements that you're making are proving durable and will be long lasting, or are these less so? How should we look at the work you're doing on operating expense discipline and the speed at which you're doing it and the need in which it has to be done?
I think that, without any major changes to any service lines, in decreasing access, that it's very difficult work in order to take expense out of the system. Healthcare is a very person-driven, human-driven industry, and so I think that by us showing that we've reduced, even with all of the salary escalations, we've reduced our salary expense by 1.5 million over the first 9 months of last year. And that's a lasting expense. We're not going to rehire those 12 FTEs. And so I think that as we invest in technology and are able to start making that shift from a person doing work to maybe where it's more appropriate for someone to schedule on their cell phone more easily. The work is very very deliberate. So I think finding benchmarks in order to hit. We know that we need to continue this work. I think that it's going to be very difficult as we move forward. I don't know if you have anything else to add.
Yeah, I think that the challenges for us are there are many, as this board knows. I want to just speak a little bit to our birthing center, which is we are the second highest delivery center in the state. We are receiving patients, several already, from someone across the state, another facility that has said they're going to close their birthing center in December. I know there's lots going on in that area, but we are absorbing these patients. I have 3 obstetricians who are managing to deliver the vast majority of these deliveries, and some midwives, and so there's quite a bit going on here that we are trying to make and answer the call from the communities in the state that need support. So as we think about how we become more, we have to become more efficient. We have to drive down our expenses, and I think there are some ways for us to do that. We are looking at that as part of the one of the challenges for us is that we actually have a quite an older population of providers. So we are going to see retirements and turnovers, significant numbers, and I am concerned about that. And so I'm really working with, I love the idea of even leveraging our relationship closer to UVM to look to see about trying to make sure that they know we have opportunities here. But that results in higher, lower productivity when I bring a new provider in, right? Somebody who is brand new out of training is going to need 3 months, potentially 6 months, to get up to speed and to become as productive as someone who's been there several years or several decades. So all of these things are going to be happening for us this year, and so we're really doing our best to look at where we can drive down some of these expenses, and partnering with the board. And again, the strategic plan, very unusual. I've been in strategic planning processes that have been focused on the hospital, focused maybe even a little bit on the local community. We are not doing that. We are engaging with the state. I think very unusual to help us understand what our next 3 to 5 years need to look like. So again, more to come on that, and would love participation from the Green Mountain Care Board.
Thank you. It's it's difficult work, right? But the cycle has been previously that operating expense grows faster than revenue, then the new operating expense is considered fixed the following year, which requires more revenue. And that type of accelerating growth, we've just run into the ceiling of what's affordable. And creating an unaffordable system is a threat to the sustainability of the system. So, and it appears as though you all understand that from the presentation. So again, I appreciate the work that you're doing. I want to ask a couple questions about the growth assumptions. You have you listed those as both opportunity and risks, and you're expecting some growth in services and some repatriation at a time when further growth would add more operating expense and raise revenue when we're trying to decrease that and have lower prices, lower revenue. So I'm just wondering how you're squaring those assumptions with expecting more care coming in while trying to reduce operating expenses.
Not every unit of care directly, it's not a direct relationship of revenue and expense. We have one additional inpatient stay. It doesn't increase revenue at the same percent or expense at the same percentage as what the expense is. So I think, being a smaller rural hospital that does not have much scale in many of our departments, building this, being able to increase in areas that we have capacity is where we're focusing on. So areas that we have capacity, we don't have to add staff. We're just going to be able to increase RVUs to be more efficient, to show that we're efficiency increases is what we're driving. So it will we're trying not to increase our operating expenses in a direct line of that revenue. And I just want to point out, if we back out the increase in 340B expenses, we're about $1 million less in expense this year projected than our budget. So we're working extremely hard to bend that trend of increasing expenses.
I noticed that and I appreciate it. I think the remainder of my questions have been covered by other questions. Thank you very much. Thank you for the work you're doing.
Thank you.
Thank you.
Great. Member Holmes?
Great, thank you. And a lot of my questions actually were answered earlier. And, I just also want to thank you for submitting a budget that aligned with our budget guidance and for all the work that you're doing to streamline operations and slow the cost growth while preserving access. That's important and we appreciate it. I think I just had two lingering questions that haven't been asked and answered. And Dr. Garcia, you just alluded to this a second ago. In the narrative, you have projected for 2026 and then the budget for fiscal year 27 admissions, broken out by med-surg, ICU, pediatrics, and maternity. And I noticed that you are projecting a decline in maternity from projected 2026 to 2027. And I wondered, with the potential closure of a nearby service, whether a decline in maternity is, an underestimate of what you might expect. And then I also noticed rather flat with pediatrics. And I wondered, given that there might be changes in that level of service in the state, how you're thinking about projections for both of those services, given potential changes that we may have on the horizon.
Sure. I think when we did this projection, we were, we weren't in the current situation where we are today. We certainly have had some further discussions with really across the state, across the southern part of the state. So I do think that our maternity projections would probably go up a bit. The other challenge for us, in a pediatric perspective, we admit very few pediatric patients here, again, outside of labor and delivery and newborn nursery, but we do, that is an area as we think about the AIM unit, coming in as a medically complex behavioral health unit. We're going to have the pediatric subspecialty or pediatric specialty support. So, kind of pediatricians to work that unit. I have 3 general pediatricians currently that do outpatient pediatrics, labor and delivery, take call, and then consult for the emergency department, and also admit if it's an appropriate admission. So that may be another number that we may be able to see some growth, but it would be really kind of towards the April, May, when the new unit comes on board. We're not anticipating being able to do that again with 3 pediatricians in the practice at this point. But I do think there may be some additional volume there as well. It's hard to know yet.
And can you just tell us a little bit about, the work that you're doing with AHS on this hospital transformation as it relates to some of these changes in, making sure that we're delivering essential services in all of our communities?
So we have been working with AHS really across the way I like to say it is, or explain it. We have the region, and so and I'm doing this because it's, Rutland and us, right? So it's this region, and then we have this region, and while we're not officially in the eastern part of the state, that is where there's quite a bit of behavioral health work that's being done, and we have joined this region because of our unit, our behavioral health unit. So from the Rutland perspective and that region, we have been looking specifically at hospice and palliative care. Rutland is really taking the lead there, and we are looking to how we could potentially work to improve care. We share a VNA, and so this really would be more of a opportunity to engage with the VNA, with Rutland and SVMC to look at, is there opportunities? What are the opportunities? There clearly are opportunities, but what are there? Where are they? And are we able to do more locally? What can we do locally? What can we do further north between? I'm not sure if everyone knows the geography. I'm new to the state, but a couple of snowstorms, and I realized that I don't enjoy driving to Rutland during the winter, and so a real challenge for our patients to be able to get all the way to Rutland, but potentially Manchester. And is there an opportunity, again, going up and down the state, is there an opportunity for us to work there? So the state is working with us on that project, and I think we've got the consultant in looking at data, and Rutland was really doing the deep dive into the data piece, and we'll continue to work with them moving forward. From a behavioral health perspective, because we are opening up the adolescent behavioral health unit, I'm a pediatric emergency medicine doc. I take care of adolescents in the emergency department all the time. When I work clinically, I don't work in the state of Vermont. You need a large volume of pediatric patients, and so I work actually in Springfield, Massachusetts. And the number of adolescents that sit in your emergency department and are essentially ignored because they have behavioral health concerns is really criminal. And I'm a lousy psychiatrist because I'm not a psychiatrist. And so we do our best to manage those patients, but working and partnering with Brattleboro, the retreat, on kind of medical complexity, what we're able to do when our unit opens, and actually the state is looking at kind of the urgent care model of behavioral health. I did this when I was in Massachusetts. I think it's a great idea to see how we could establish that in our region. That's being done, will be done, I think, in the Springfield area. And so opportunities to think about, could that be done in other areas of the state? So we've had those those conversations as well. And I appreciate the state bringing us into different regions conversations on how we meet the needs. We will take from that region, obviously as part of a state receiving facility, adolescents with medical complexity once our unit opens in April, and then we will be able to get to that part of the state, those individuals that don't have medical complexity but need behavioral health admissions. So that's one way we're partnering kind of across the state, but we're also looking at other opportunities specifically for ourselves. We have put in a request, I think we mentioned it in our slides, to have some lean. We do not have lean support currently. We would love to be able to look at the processes across our system and figure out where the opportunities are that we've missed. And so we'd love to get some support to do that financially through a rural transformation grant as well, and as well as other workforce grants that we're currently looking at to build that pipeline of workforce. So those are things we're looking for as we're partnering with the state in areas. And then our big push is the primary care residency program. Just so that everybody here is aware, other states, not including Vermont, specifically said of the rural transformation dollars that are here, and I think it was numbers in the 20s, states have said rural teaching programs should have dollars attributed directly to them. The state of Vermont did not do that. The state of Vermont picked to support the Maple Mountain program, and there are some dollars, I would say small dollars, that are going to that program, but that was not an option for us as we're building our residency program here in Bennington. And so one of the things that would like the state to do is to, for round 2, is to actually put some dollars into rural GME training programs, because I do think we can do it in a different way than it's being done, at UVM or across the border at DH, if we do these in our community sites, partnering with community providers.
And do you have a sum total of estimated cost savings that apart from the rural health transformation funding, but just the transformation plans that you're working on with AHS and potentially with other regional collaborators, just an estimated cost savings of if all of these programs are implemented, or what would be the sum total of cost savings?
I do not have those numbers. I think that is Kaufman Hall has joined as part of the work that's being done across the state, and part of I do believe that part of the work, and we are meeting with them as every hospital is, to look at their transformation plans. I do believe that part of their work is to help us come up with those figures, because again, unfortunately, the work that we're doing with the state around transformation didn't come with any administrative support. And one of the things that we've done at this organization, in partnership with the board, Green Mountain Care Board, is to reduce administrative overhead, and that often is those individuals who could help with some of those, some of those programming. And so I do appreciate that the state is going to bring some of that to bear with Kaufman Hall. We're looking forward to that, but I don't have the numbers specifically at this time.
Okay, and I think Chair Foster asked this, but there aren't any numbers baked into your budget then for next year, assume, because you don't have the estimates.
Correct.
My last question actually is just around the Vermont Medicaid global budget assumptions for 2027. I know when you submitted this budget, you assumed a global budget, and my understanding is that program may not continue. And so how will that change your budget forecasting if there's not a Medicaid global budget?
You're correct. That program is ending, has ended, and we'll be going back to paid on a fee-for-service basis. We've been tracking we did budget at the global budget amount that we were there, but through the first 6 months of tracking the global budget versus what we would have been paid under fee-for-service, it is not a material. We will be paid less, but it will not be material. We would have been paid less under the global budget, but it won't be materially less. It won't impact the financials gravely.
Okay. Okay. Thank you. I think those are my questions, Chair Foster. Thank you very much for the presentation today.
Thank you. I had one more. Under our statutes, we are required to look at executive compensation. And I noticed there seems to be a big disparity between fiscal year 26 budgeted executive compensation and 26 projected salary. For example, the highest paid employee in the 26 budget was $548,000, but the projected salary for 26 the same year is $639,000. And relatedly, the second highest compensated employee was 384 budget, but 428 projected. And this is kind of across a number of different positions. Can you explain the delta between what was budgeted and what's projected?
The most of the differences is related to the restructuring of the positions and the elimination of certain individuals and then other individuals taking on additional roles.
Was there,
I'd have to look at the exact, I don't have that file open up on my computer to look at the tick and tie, but that would be my high level.
okay, could you send us and follow up the documentation explaining the increase
Sure.
from budgeted to projected, and
Sure.
if it relates to additional roles and responsibilities, just seeing that
Sure.
modeling and calculation would be very helpful. And then one other related question on that same document. I'm sorry, I didn't prepare it to show you, but it's on the document with the fiscal year 26 budgeted and projected executive compensation. There's a line that says Garcia Packard Wager -DH employees. I assume that's referring to Dr. Garcia. Who are Packard and Wager?
So yeah, so those are employees that are not run through SVMC payroll. They are Dartmouth Health employees that are 100% working at SVMC. So they, Karen Packard is our director of the Dartmouth Cancer Center in Bennington, and Wagar is the physicist.
Okay.
Matt Wagar is the physicist. So
Got it.
they're employees, but we reimburse Dartmouth at cost for their salaries. Because they're Dartmouth employees.
I see. So the figures that are included here are the amount, the total compensation. However, that compensation is paid by Dartmouth Hitchcock, and SVMC reimburses it dollar for dollar.
Correct.
Okay, great. All right. Thank you. I had no other questions, and I'll turn it to the healthcare advocate for any questions or comments.
Yeah, good morning. Thank you very much for the presentation. Just two questions, and apologies, I'm battling a bit of a cold. So if you can't understand what I'm saying, just let me know. One tool, obviously, for reducing high commercial prices is reference-based pricing. And I'm wondering if you support that effort and or what barriers you would see to complying with reference-based pricing as it's rolled out in Vermont.
Sure. I think that we need to make healthcare more affordable, and we are working to do that. Whether it's reference-based pricing, whether it's global budget, whether it's a reduction in reimbursement, we're supportive of making healthcare more affordable. I think from a system perspective, our medical record and billing system is quite old, so making a change is going to be administratively burdensome. We are moving to Epic, which will greatly help with that, and we anticipate that greatly helping with that. And so from an administrative portion, it should be easier. I think that we have to remember that hospitals provide a critical service, and maintaining an adequate reimbursement in order to maintain those critical services is important. And that's why SVMC is reducing our expenses, so that way we can weather that reduction in reimbursement.
Thank you. I appreciate that.
Long-winded way of saying yes. Yes, we recognize that reimbursement has to transform, and we are working to do that. But we need to maintain. We can't do it by eliminating access to services.
Got it. Thank you. My last question is how you all evaluate the contract with an ACO, Reach ACO. You mentioned Belong Health. Like, what metrics do you use to evaluate whether or not that's working for the hospital and for patients?
Sure. I think that we looking at the we are able to look at the quality metrics, the readmission rates, and then also the biggest part that I look at. I can let Esteban talk about some of the quality measures, but the financial impact for the organization and how much of and being able to access those shared savings from Medicare based on what the work that we're doing to reduce the cost of the Medicare program, and being able to account for and receive those savings to be reinvested.
Sure, and we meet with them on a monthly basis in our executive management team has a presentation to let us know how we're doing, where are what are we looking at, the quality outcomes up to that point. So it actually is very collaborative, which is different than I think sometimes these types of situations. And we're not waiting for 6 months or a year to know if it's making a difference. It's actually an ongoing engagement with them. So absolutely, the quality metrics are important, the readmission metrics, the utilization metrics, and then to Bob's point, are there shared savings that we may be able to reinvest?
Okay. Thank you. I appreciate that. It seems like you're aware that sometimes these ACOs have a mixed track record of success. So I just appreciate that you're aware of that. Thank you.
Thank you, Mr. Peisch. Any public comment via raise the hand? Okay, seeing none. Mr. Garcia, Dr. Garcia, Mr. Green, and Mr. Laba, thank you so much for your presentation and all your work at this hospital and for the community. We will take a recess until 12:30. At 12:30, we will resume with 12:15, the Northwestern Medical Center budget. So thank you all and have a good day.
Thank you.
Thank you.
Thank you.